Thanks, Dr. Moran, for the introduction, and sincere thanks to Dr. Kinney and Dr. Sharma for having me here today. I remember sitting in these seats as a medical student, excited to first start learning about cardiology, and now to be here 15 years later on the podium is quite humbling, so thank you for that. So I'll be talking about cardiogenic shock and STEMI today, and I think that the two main trials that have come out in the last year is what I'm going to emphasize in this talk, and that's the ECLS shock trial and the DanGer shock trial. So I'll start with the ECLS shock trial, and many of us know this was a trial of patients with acute myocardial infarction and cardiogenic shock. Cardiogenic shock was defined by a blood pressure of less than 90, end organ damage, and a lactate of greater than 3. They were able to take 420 patients and randomize in one-to-one fashion to ECLS plus PCI versus PCI and optimal medical therapy alone. The arm that received optimal medical therapy was monitored for worsening signs of cardiogenic shock. This was defined as a lactate increase of greater than 3 over 6 hours, or a doubling of drips that was required to maintain a MAP of greater than 65. In this group, if cardiogenic shock did worsen, they were allowed to use mechanical circulatory support devices, but ECMO was strongly discouraged. The primary outcome of this trial was 30-day mortality. And what you can see here on the left is the KaplanMeier curve that shows the outcomes of this trial. So there was no difference in 30-day mortality in either group. And if you look on the right, perhaps more importantly, is the safety endpoints. And specifically, if you look at moderate to severe bleeding or peripheral ischemic vascular complications, there's a significant increase in the ECLS group. So in the moderate to severe bleeding, there was a relative risk of 2.44, and in the peripheral ischemic complications, there was a relative risk of 2.86. So I think the conclusion from this trial is that there's no difference in 30-day all-cause mortality when using ECLS with PCI for STEMI-related cardiogenic shock, and instead there's a significant increase in complications and specifically bleeding and vascular complications. Now, there is some limitations I think we have to acknowledge here before extrapolating this into clinical practice, and first and foremost, there were very liberal inclusion criteria in this trial, which may not reflect what we all do in clinical practice. So there were a lot of patients of advanced age, greater than 25% were more than 70 years of age in both groups, and very, very sick cohort, 78% in both groups underwent cardiopulmonary resuscitation before randomization, so very sick. Despite ECMO being discouraged in the control group, there was a 12% crossover rate, which can separate the signal between the two groups, as we all know. And also, despite knowing that LV venting when using ECMO can help promote LV recovery, there was very low rates of LV unloading. Only 5.8% of patients in the ECMO group received LV unloading, and how this impacted the results we're not totally sure. But I think what we can extrapolate into clinical practice is that ECMO should definitely not be used on a routine basis for those with STEMI and initial signs of cardiogenic shock. So DanGer shock is the next trial that came out more recently. And this is a trial that looked at those with acute MI and cardiogenic shock. Cardiogenic shock here was defined as a blood pressure of less than 100, a lactate of greater than 2.5, and a left ventricular ejection fraction of less than 45%. They were able to take 355 patients and randomize in one-to-one fashion to PCI alone versus a microaxial flow pump plus PCI. Both of these groups were evaluated for worsening cardiogenic shock, and escalation of MCS was allowed in both arms, but Impella was discouraged in the control group. The primary outcome of this trial was 180-day mortality, and the results are shown here on the left. The KaplanMeier curve shows that there is a significant decrease in mortality when the use of a microaxial flow pump was included in care, and it was so significant that the number needed to treat here was 8, which is a really exciting result. To temper the excitement, there was a significant signal of harm, which I think we all have to acknowledge, and the safety endpoint that was used here was a composite endpoint. This composite endpoint looked at a culmination of severe bleeding, limb ischemia, hemolysis, device failure, and worsening aortic regurgitation. And you can see here that there's a significant increase in the microaxial flow group, and the number needed to harm here was actually 6. So I think what we concluded from this is that routine use of a microaxial flow pump certainly can reduce mortality and STEMI-related cardiogenic shock at 180 days, but we do have to understand that this comes with a significant increase in complications. But more than just that message, I think if we look at the appendix of this trial, we take some really granular things that we can extrapolate into clinical practice. And one of those things is the escalation protocol that they define in the appendix. And this is the figure that they have there that talks about their management in the ICU of these devices. And I want to highlight a couple things. You can see in the beginning here, that on days 0 to 2, there is no device weaning, no matter what. So the device is run at the highest power for 48 hours with no attempts at weaning, which I think is not routinely always what we did in clinical practice, but perhaps part of the reason why they saw such a strong signal of benefit here. After those 2 days have passed, between days 3 and 5, there are attempts at weaning. But I think more interestingly, if by day 5 the device is unable to be weaned, that device is removed no matter what, and it is escalated to an alternative device, whether that's VA ECMO, an LVAD, or an Impella 5.5. So I think it gives us a clear endpoint in clinical practice on when to think about, switching the unweanable patient. Also, further that point, they give a very clear weaning protocol. And like I said, there is no weaning when the device is in for less than 48 hours. But after that 48-hour mark, if the patient is on less than or equal to 2 drips and achieves 3 of 4 of the following, which is a cardiac index of greater than 2, an SVO2 of greater than 55%, a lactate of less than 2.5, and a pH of greater than 7.3, this patient is considered ready to wean. And the power level on the Impella is reduced by 1. All of these metrics are rechecked, and this is repeated on an hourly basis until all of these metrics are stable on 1 liter per minute, and that's when the device is removed. To define what these maximum drip dose rates are, which are sometimes lower than the ones we use in clinical practice, which is why I think it's important to emphasize here, dobutamine at 10 micrograms per kilogram per minute, dopamine at 10 micrograms per kilogram per minute, milrinone at 0.4 micrograms per kilogram per minute, and noradrenaline at 0.15 micrograms per kilogram per minute. So you can be on 2 of these drips, but no more. Just a couple of considerations here, again, before we extrapolate all of this into clinical practice. I think it's really important to emphasize that severe RV failure was excluded here, and of course there is going to be a subset of patients that we see with STEMI-related cardiogenic shock that have RV failure, and this does not apply to that patient group. Also, despite the compelling effects of the microaxial flow pump, there was still significant amounts of hemodynamic support escalation required in the experimental group. So 11.7% of these patients did require escalation to VA ECMO, 3.9% required escalation to Impella 5, and 5.6% required a durable LVAD. Also, I think a lot of this benefit was driven by the subgroup that was defined to benefit the most from this intervention, which is those who are male, those that had a mean arterial pressure of less than 64 on randomization, and those that had greater than or equal to 2-vessel coronary artery disease. So despite this adding a lot to our knowledge base on how to take care of these patients, there are still upcoming trials that I think are going to, add just as much or if not more. So there's 2 major trials that are coming out soon in regards to Impella. One is called Door to Unload. This is a trial of those with anterior wall MI actually who don't have cardiogenic shock. Those patients will be randomized 1-to-1 to Impella placement and running for 30 minutes prior to PCI versus immediate PCI. And the primary outcome of this trial will be infarct size as measured by MRI. And Recover 4, which is run by Abiomed, is going to be a STEMI-related cardiogenic shock trial, randomized 1-to-1 for Impella plus PCI versus PCI with optimal medical therapy, which may or may not include intra-aortic balloon pump. The primary outcome of this trial will be 30-day mortality. And similarly, there's some very exciting trials in regards to ECMO that we hope will come out soon. 2 of the most anticipated are the ANCHOR trial. The ANCHOR trial is a trial of cardiogenic shock complicating acute MI, whether that's STEMI or non-STEMI. Patients will be randomized to VA ECMO plus a balloon pump plus PCI versus optimal medical therapy plus PCI. And the primary outcome of this trial will be treatment failure at 30 days, which is defined as death or crossover to the mechanical support arm. And then another trial called Unload ECMO is going to look at severe cardiogenic shock due to left ventricular dysfunction of any etiology, ischemic or non-ischemic, and patients will be randomized to VA ECMO versus VA ECMO plus Impella. And the primary outcome of this trial will be time to death within the 30 days after randomization. So just some conclusions before I finish up. I think what we can take from this data over the last year is that Impella should definitely be considered first-line device for the management of STEMI-related cardiogenic shock. And I think we should also know that ECMO should not be used as a first-line device, but still does have a role, specifically in those who are under-supported by Impella and those who either present in biventricular failure or develop biventricular failure along their course. Optimal ICU management is critical in achieving success that we've seen in these trials, and hopefully with more data, we'll better understand when and which patients to use mechanical circulatory support in this very critically ill subset of patients. So thanks again for having me here today.